Good afternoon, everyone, and welcome to the 76th of the COVID calls. This is a daily discussion of the COVID-19 pandemic with a diverse collection of disaster experts. My name is Scott Gabriel Knowles. I'm a historian of disasters at Drexel University in Philadelphia. Today, we have a discussion of COVID-19 and vaccines with Dr. Paul Offit. You can catch COVID calls live every weekday at 5 p.m. Eastern Time on YouTube Live. Just go to the COVID Calls YouTube channel to watch. You can hear COVID calls recorded as podcasts on Spotify, Stitcher, iTunes, Podbean, or anywhere you get podcasts. You can also keep up with COVID calls via Twitter using the handle @USOFDisaster or @COVIDCalls. Please do help spread the word and send suggestions for future guests and topics, and please feel free to suggest yourself as a future guest. As of today, June 29th, 2020, there are 10,195,680 confirmed cases of COVID-19 globally, according to the Johns Hopkins University Coronavirus Resource Center. That's up from 9,695,375 Friday. Of those, 2,562,921 are in the United States. That's up from 2,453,044 reported on Friday. There are now a total of 125,927 deaths reported from COVID-19 in the United States, up from 124,891 deaths reported on Friday. As a way to bring humanity to the numbers, I've been reading a life story or a story of advocacy for COVID-19 sufferers every day, and I'd like to continue that now. The headline is Eric Gore, 48, carried on a family tradition as a Philadelphia firefighter. This appeared in the Philadelphia Inquirer June 10th by Gary Miles. By all accounts, Eric Gore was a quiet man. He was private, said older brother Lamont. He didn't do a lot of talking, said colleague Lisa Forrest. Instead, Mr. Gore made noise with his actions. He was a Philadelphia firefighter, published writer, former Philly policeman, former court stenographer, world traveler, father, and husband and philanthropist. And even though he didn't say much, he could say it in English, Spanish, and Mandarin. He was the kind of guy who would give money to kids he met even when he couldn't spare it, said Lamont Gore, also a Philly firefighter with Ladder 15 in Frankfurt. I had to tell him to stop it and spend that money at home. Mr. Gore, 48, died June 2nd at Temple University Hospital due to COVID-19. Like his brother and late father, Edward, Mr. Gore found a home away from home with the fire department. He grew up in Southwest Philly, near 58th and Baltimore, and graduated from Bartram High School in 1990. He went on to work for 3 years as a Philadelphia police officer, then joined the fire department in 1996 and worked across the city for more than 23 years, spending 12 years at Engine 61 in Olney. In 2002, Mr. Gore and others in his unit were cited for helping rescue 2 children and an adult from a burning home. He had been assigned to Engine 37 in Chestnut Hill for the last 2 years. It's in our blood, Lamont Gore said of the family's civic service. His wife, Deborah, is a police detective, and many relatives have worked for either the police or fire departments. Despite his laid-back nature, Mr. Gore impressed those around him with a no-nonsense approach to work and his wide array of interests. Forrest, a captain in the fire department, said Mr. Gore was an action person. He never started any trouble, but he was not one to back down either. Lamont Gore said Eric was the perfect little brother when they were growing up. Little brothers are supposed to take whatever big brothers do and smile about it, he joked, and Eric did that. Mr. Gore was so reserved that Lamont did not know that his brother had visited China until he had already returned. His 2016 novel, Vengeance Obtained, was about Marcel Ducret, a 900-year-old vampire. He found time to do a lot of stuff, Lamont Gore said. He is to be posthumously promoted to lieutenant. I'd like to turn to our discussion today, and I'm really thrilled to have Dr. Paul Offit here today on COVID Calls. Let me introduce him. Paul Offit is a pediatrician specializing in infectious diseases and an expert on vaccines, immunology, and virology. He is the co-inventor of a rotavirus vaccine that has been credited with saving hundreds of lives every day. Offit is the Maurice R. Hillman Professor of Vaccinology, Professor of Pediatrics at the Perelman School of Medicine at the University of Pennsylvania, and the Director of the Vaccine Education Center at the Children's Hospital of Philadelphia. He has been a member of the Centers for Disease Control and Prevention Advisory Committee on Immunization Practices. Offit is a board member of Every Child by Two and a founding board member of the Autism Science Foundation. His most recent book is Overkill: When Modern Medicine Goes Too Far. He's also the author of Bad Advice, or Why Celebrities, Politicians, and Activists Aren't Your Best Source of Health Information. He's also the author of many other books. I'll just name a few other titles here: Pandora's Lab, as well as The Cutter Incident: How America's First Polio Vaccine Led to Today's Growing Vaccine Crisis, and Deadly Choices: How the Anti-Vaccine Movement Threatens Us All, which came out with Basic Books in 2011. It was selected by Kirkus Reviews and Book List as one of the best nonfiction books of that year. Paul Offit, thanks for making time. Welcome to COVID Calls.
Thanks, Scott. My pleasure.
I'd like to start the way I've been starting all of these calls, which is just to ask where you're calling in from and what's the COVID-19 situation there today.
I am in Avalon, New Jersey, at a shore house with my wife, my daughter and her boyfriend, who now is unfortunately in a unwittingly part of a Scared Straight program for being part of our family. My son, who was here just recently, left to go to San Francisco, and then my sister's son, my nephew, and his pregnant wife. So we had 7 people here. Now we're down to 6, but that's the clan. And what the situation is it's crowded. It's actually crowded here. It's a shore town. And just a couple of days ago at a local bar and restaurant, there were more than 100 people there. They were all crowded together. Nobody had a mask on. And you just see a situation like that and wonder why it is that they did it. I can't believe that bar or restaurant was allowed to do that. 2, that the mayor allowed that to happen, that the police force allowed that to happen. I mean, we're just asking for trouble. It's hard to watch.
In a situation like that, I wonder how you restrain yourself. I mean, you can't right every wrong in the public health world, the medicine world, but what are your feelings when you see that kind of crowding happen?
Well, we wrote to the mayor. I mean, we got in touch with the mayor and said, this is what just happened in your community. I mean, this is puts those in that room at risk, and it puts those who then come in contact with people who were in that room at risk. It's just it's unconscionable. It's exceptionally, it's not just stupid, it's just selfish. I mean, you wear a mask to protect you and to protect others. It was a young crowd, obviously, but young crowds do ultimately interact with older crowds. And even when you're a young person, you can still die from this virus. Your risk is less, but it's not zero.
Has there been any social protest there, anything in reaction to George Floyd down at the shore?
A little bit, yeah. There have been. Rio Grande, which is not far from here, had a small protest. But this frankly is Trump country. I mean, this area, Avalon, New Jersey, is Trump country. You see occasionally the planes will fly by with the banners that say, Trump 2020. So yeah. Right. I got to get out of here. That's what I'm saying. But yeah.
Got it. I got it. Well, there's a lot of ground I want to cover today. Certainly, we want to talk about the vaccine situation for COVID-19, but I'd like to ramp up to it for people who may not be as familiar with your work. I guess I'd like to start, if you don't mind, just to get a little sense of you, how you first got interested in medicine, if you don't mind sharing that with us, and then how your interest grew into this sort of really important space around vaccine development.
I think the real answer to why I got interested in medicine was that I was in a polio ward when I was 5 years old, and I just remember seeing those children as vulnerable and helpless and alone. I didn't have polio. I'd had a poorly performed surgery on my right foot that has been a problem ever since. But that landed me in that polio ward for about 6 weeks, and this was at a time before there were play therapists or pet therapy, kind of pet therapy, or parents couldn't stay there. There was only one visiting hour a week. My parents were able to come on Sundays from 2 to 3. My mother couldn't come because she was ill. My father snuck in one day and then was barred from coming again. So I just remember how isolating and alone that was. And I guess at some level we all treat ourselves. And I guess that's what happened to me. I just saw those children as victims. And I think that's always been true for me ever since. I think it's why I went into pediatrics. I think because I was in a polio ward is why I went into pediatric infectious disease. I think it's why I wrote a book about the Cutter Incident, which was a polio vaccine gone badly. And I think all my books have at their heart kind of child advocacy.
So you said this is when you were 5. You were in the hospital for 6 weeks.
That's right.
Wow. So you must have made friends with the kids in the ward, I would imagine, too.
Nope, not at all. It was very isolating. We all just were in our
Oh,
separate beds or isolated or, sort of our lungs or, traction. No, there was no interaction. Not at all.
I
You were
see.
just alone. I
But
mean,
that's
my bed was right near the window that overlooked the front door or the entrance to the hospital. I just remember staring out that window for all my waking hours, hoping that my parents would come visit me, save me, but it didn't happen.
that sense of isolation. I mean, it's really struck me about COVID-19 too. That it's such a, I mean, maybe the way we experience disaster more generally, it's often more in public. And pandemic, particularly this one, so much of it has been in private. I know not from the physician's perspective, maybe, but from the general public, so much of the suffering and death has been behind the walls of the hospital or just sort of out of sight. And I've wondered what kind of impact that has on the ability of the public to rouse the appropriate amount of fear or empathy. I don't know how you think about that.
No, I think it's a really good point. You have to deny reality to, for example, go out into a crowded area and not wear a mask. I mean, how much more information do we need that there's, been millions of cases and more than 100,000 deaths in this country. I mean, it's all there to see. But I guess it's just for most people a statistic. Most people probably don't know someone who's died. I mean, I do know someone who's died of COVID-19, but I think many people don't know that, so they just see this as fake news. I mean, you see a president who doesn't wear a mask, who basically has just been denying this for the last couple of months, and they're willing to deny it too. It's just hard to believe you can deny reality like this one, but people seem to be able to do that. You have public health officials who recommend wearing masks who are threatened. You have security guards who recommend people wear masks who are threatened. It's madness. I mean, it's a country that was founded on individual rights and freedoms, and we take that to its illogical end, which is to say that it's your right then to catch and transmit a potentially fatal infection. I mean, it's not. It certainly shouldn't be.
So I have been reluctant to invite physicians on to COVID calls up to now just because of the pressing needs on your time. And Esther Chernak, who's a colleague of mine at Drexel, been kind enough to come on several times, and she had suggested I speak to you. And one of the reasons I was really thrilled to talk with you, I mean, I want to get your perspective on the full scope of what we've seen, how it's played out, but I'm particularly interested in the earlier phase. What kind of things do you watch for? What were you, if you can reconstruct January, February, March, in that period of time, it feels like 10 years ago now, what were you watching for in terms of public health statistics as you were making sense of what was happening? Can you walk us through a little bit, like your sense of concern, alarm, sketch it out for us a little bit?
I completely underrated what was about to happen in this country. I mean, I did some early interviews at the beginning of March, and I couldn't imagine that this virus would do what influenza does, which is just typical, epidemic seasonal influenza does. I mean, influenza this year, for example, caused about 50 million cases. It caused about 780,000 people to be hospitalized, and it caused about 60,000 people to die. I never imagined this virus would be close to that, and said that on a few national and international news programs, thus officially making an idiot of myself. And the reason I did it was I looked at other countries like China or Japan or Singapore or South Korea and looked at how big those populations were, the number of cases and deaths that occurred in that population, then extrapolated it to our population, not realizing we'd be so bad at this that, that we have 4% of the world's population and, 20% of its deaths, more than 20% of its deaths. I never imagined we would be this bad at it, but I was wrong. I underestimated how much we were able to ignore public health advice and how bad we were at getting personal protective equipment out there, how bad we were at restricting travel initially. I mean, how bad we were at having clear direction from the administration, and at some level, clear direction even from governors. And we just sort of got worse and worse, and we're still fighting this. We're still catching the tail of this virus. I never imagined we would be this bad at doing this. We're one, if not the worst, we're certainly one of the worst countries in the world at getting on top of this.
When you read about a pandemic or an epidemic when it's still at that phase, what kind of what do you read? I mean, do you look at the WHO announcements? I mean, you're keeping up obviously with medical literature. Just coming back to January, because as you're saying, you didn't expect it would grow into something worse than seasonal flu, and we'll come to maybe some of the reasons why it did. But those sort of first data points that you're looking for every year, where are you pulling those from?
All right. So again, I'm not an epidemiologist. I'm a virologist. So I'm on the NIH's so-called active group, which was a group that was put together by Francis Collins, who's head of NIH, to try and facilitate or accelerate the development of a vaccine. So that's been my focus. Remember, there's about 4,000 articles published a day in the world's medical and scientific literature about this virus. So I don't read all of them. I just read the things that are related to what I'm interested in, which is the biology of this particular virus and the vaccine story. That's where I focus my attention.
Okay. And so as we move into March, and you're saying you sort of said you underestimated it, and you started to change your opinion as things, I presume, move into March and April. What do you think were the critical points there? Because it won't be enough later as we go back and try to reconstruct this to say it was just Trump. That to me seems like a question and not an answer. Can we go a little further with that? What were the key missed opportunities there, particularly in that month of March, that might have brought the death toll down where we are now?
I think, although obviously Trump doesn't help in this with his consistent sort of denial of what's going on and his inability to wear a mask, I do think that it's us. I mean, I think it's the nature of this country. I think Trump is more a symptom than the problem. I mean, what Trump shows is that we're willing to deny reality at a certain level in many things. I mean, he takes the phrase climate change off of the EPA's website. It tells you he denies reality. When he has an inauguration that has 1/3 the size of that for Obama, I mean, I see overhead, pictures of those two inaugurations. It's clearly a huge difference. And he asks his followers to believe him. And he said, quote, "Believe what I say and not what you see." I mean, he's a cult leader in many ways. And to be a cult leader, you have to be willing as a follower to restrict access to information or just to deny information, which we all sort of put under the rubric of fake news. So I think we're a country that's willing to do that. We have a significant percentage of people who are willing to do that, to sort of deny reality. We're also at our hearts libertarians. We don't like to have the government tell us what to do. We like to be individual actors. There's a cowboyism that allows us to not wear masks when we're out there and say the government shouldn't tell me to wear a mask. It's my decision whether to wear a mask. But again, you're making a decision for other people. So I think there's a lot that goes into how bad we are at this. But at heart, in many ways, it's who we are.
And have there been particular states or governors or leaders in any sector that you feel like have managed it well? I mean, what are the bright spots, to the extent that there are some? Trump, obviously not, but where have you taken some solace?
I think Cuomo eventually managed it well. I mean, initially he was letting people who had COVID-19 go into nursing homes, which was not a good idea. But eventually, I think he got on top of it and was have daily conferences and let people know where he stood. And he really shut things down, and things got better in an area where it was awful. So there are some governors who've been better. I think Phil Murphy in New Jersey has been pretty good. But then there's people like DeSantis in Florida or the governor of Texas who are they were going to be loyal patriots to Donald Trump and just trying to deny this and let's all go back to work, and now they're suffering those decisions.
I want to remind people you're listening to COVID Calls, and I'm talking today to Dr. Paul Offit. You can get your questions in on YouTube Live. Just put them right there in the YouTube Live chat. You can put them up on Twitter. Just tag me at US of Disaster, and you can email them to me if you want to, sgk23@drexel.edu. I want to just stick with this a little bit more about Trump, just because you're an expert in bad advice, the willingness of celebrities to give medical advice, quack medicine. Were you surprised by the hydroxychloroquine episode, the household cleaners episode, the light therapy episode? Did that surprise you at all?
Well, not from Trump. I mean, I think he's not the science president. I think when he's asking you to, essentially take Clorox chewables, I made that up, but the notion that disinfectants ingested or injected could cure this. I mean, he's he's just not very smart when it comes to science. So that he says those things doesn't surprise me. What really upset me in that was the Food and Drug Administration. I mean, that he was able to bully the Food and Drug Administration to, under the EUA, Emergency Use Authorization, allow for that product to be used when there was no evidence that it was of value. None. Wait for a controlled trial. I mean, you can do a controlled trial pretty quickly. There were plenty of people in this country who had the disease. Treat half, don't treat the other half. You can do 1,000 people very quickly, as we did with the antiviral drug remdesivir. Do that, wait for that, and then give it at least an approval, if not licensure, for that for that disease. They didn't wait, and so we know from placebo-controlled trials that it not only didn't work to treat it, didn't even work to prevent this disease, and it had known cardiac toxicities. I mean, you knew that drug could cause arrhythmias. So it did far more good. It didn't do any good. And I blame the FDA for that. I think the FDA was at its worst for that. And that's what upset me the most. I mean, that Trump says stupid things is not a shocker. I do think that the FDA was willing to be bullied by this man, this administration. Was really depressing to me.
But that raises some general concern that people have raised throughout the presidency about what's going on at NOAA or EPA and other sectors. But I guess, speak for myself, I've kind of felt like CDC, HHS, FDA, that maybe there's political appointees at the top, but these places are stacked with career scientists whose reputations they take very seriously. They take the science very seriously. What's happened with the governance within something like FDA to allow that to happen?
Yeah, so the science has been politicized. I mean, I think the NIH is generally untouched, but you look at CDC, you have, these amazing, brilliant, dedicated public health officials like Nancy Messonnier or Anne Schuchat. We should be hearing from them every day. We should be hearing from the CDC every day, much as we heard about it during the Ebola outbreak in West Africa. And there were people who came from West Africa to the United States who had the disease. This was obviously far less of a threat to the United States than this virus is. But that's who we should be hearing from. And they've gotten sidelined politically. I guess the Trump administration didn't like what Nancy Messonnier said early on when she said it's not a matter of whether we're going to have a problem in this country, but when. I mean, that in retrospect, that's about as mild of a statement as you could imagine. And she said early on, I think on the Rachel Maddow show, that this would change our life. And then you never heard from her again. And that's ridiculous. I mean, this is I don't know if you know Nancy Messonnier, but she's just a brilliant, dedicated public health official. She's just the voice that you want to hear, as is Anne Schuchat, who's the assistant CDC director. But those aren't the voices you hear, which is too bad, because I guess the administration doesn't like what they're going to say. So you hear from Deborah Birx, or you hear from Robert Redfield, and I would much rather hear from the other two.
Are there any kind of controls in place, though, in a place like CDC or FDA with a inspector general process? I mean, I guess many of us, myself included, are wondering, how will you make it right? How do you learn from these kind of failures? Again, it won't be enough in the long run for us to shrug our shoulders and say, well, that's the Trump administration. Don't we have to learn from these kind of key failures in these agencies?
I mean, scientists walk out of the EPA, lawyers walk out of the Department of Justice, inspectors general get fired or leave. I mean, I think what we're learning is that we have the principal law enforcement agent of the land, William Barr is Trump's personal lawyer, and so we've lost the rule of law in this land. And I guess the only way out of this is to change the administration, hopefully in November, because I don't know how we live through 4 more years of this. It's nightmarish. I'm a Democrat. I don't know if that came through with any of this, but. Although I'd like to say this,
it did, but
my parents were conservative Republicans. I really think if the Republicans actually were what Republicans once were, which they aren't anymore, this has nothing to do with conservatism and nothing to do with really what the Republican Party was. I mean, there really is no choice. I don't know what this party is. It's like the white supremacist party.
Well, I don't think anybody, no matter their party affiliation, would want government to turn its back on obvious scientific knowledge that can save lives. I mean, I think that seems to be, and I think the polls are sort of holding that up as well, even in states like Texas and Florida, where people are still listening to public health officials, despite the fact that they're in those environments. I wanted to just make a comment as a historian who doesn't also develop vaccines. I just am a historian, and it's enough for me to try to write books, and I can't keep up with the pace of your books. I have no idea how you are so productive. And probably you should write a book about how you do all that. But I want to turn to your thinking about the history of medicine here a little bit. And just a kind of general question to start. What are the pandemics and epidemics that you still think about? Even ones you may have written about. What are the ones that you keep going back to in history and you keep learning from?
Well, I mean, the most devastating ones, obviously, were the flu pandemic of 1918, 1919. There were hundreds of millions died. The smallpox epidemic, which killed 1 out of every 3 people that was infected, was, killed probably 500 million people in the world's history. It changed the course of European history, as monarch after monarch, was felled by this virus. But the disease that captured me, obviously, is why I wrote a book about it, was polio. I mean, that to me was such a devastating illness. One, it attacked healthy young children. It paralyzed them for the rest of their lives, or put them in iron lungs for what remained of their lives. It killed 1,500 children a year, and nobody really knew how you got it. It was only 1 of every 200 people who got polio that was paralyzed by it. So what you saw was just the tip of a very big iceberg. And, that affected my life because, my parents, I was a child of the 50s, and my parents wouldn't let us go to public swimming pools in the summer. I think it's why summer camps existed, to get people out of the cities so they could go to more rural areas and try and get them out of the way of harm's way of polio. But that was just such a devastating illness, and there were just so many heroes associated with that. People who did the work to eventually eliminate it. I mean, we haven't had a case of natural or wild type polio in this country since the 1970s, when it was all we talked about in the 50s, 40s, 60s.
What was the process of vaccine development around polio? I mean, and more generally, like, what were the rules about making a vaccine in those days?
Right. Well, very similar to the rules today. I mean, you had two polio vaccines that were made in the 1930s, one by Maurice Brody, another by John Comer, which were bad vaccines. I mean, it's turned out that they actually caused polio as much as they prevented it. So that was bad. And it set polio research back about 20 years. And then in the 1950s, Jonas Salk stepped up along with other researchers, figured out how to grow the virus in non-neural cells, meaning not cells from the brain or spinal cord, which can be problematic. And then he, grew up the virus and activated it with formaldehyde. And to me, it's relevant today. That story is relevant to today because as bad as polio was, as terrifying as it was, as paralyzing as it was, we waited for a phase 3 trial before we put that vaccine out into the arms of children. The vaccine was tested by Jonas Salk in about 700 people in the Pittsburgh area. It was safe. It certainly looked to induce a great immune response, but we waited to do a trial of 420,000 children got a vaccine, 200,000 got placebo, and that took a year to do. And then when the vaccine was shown to be safe and effective, then and only then did we put it out there. And I just like to see, what worries me the most about this is we're coming up to November 3rd, and you hear company after company are talking about October. Even Tony Fauci has talked about October, and I just don't see how we can have phase 3 trials, meaning 30,000 people, either 20,000 vaccine, 10,000 placebo, or 15,000 vaccine, 15,000 placebo, which is what the NIH active group is now recommending. I don't see how we get that done by October. So when they're saying October, I just worry that they're going to, pull one of the vaccines out of the so-called warp speed bucket, which is basically a manufacturing thing where vaccines are being mass-produced at risk because you don't know whether the vaccine is going to work or is safe, and say, look, we tested this in a few thousand people. It looked like it's safe. We get great immune responses, although the immune responses aren't always predictive of protection, as we know from probably half the vaccines that are currently on the market. And then say, okay, so we're going to put it out there. And then really, then essentially what they're saying is we're going to learn whether it was effective after it's already out there commercially. And I think it's a fragile vaccine confidence in this country. I really hope we don't do that, but I am really worried we are, which is why Zeke Emanuel and I wrote that op-ed in the New York Times about the October surprise.
Well, I want to come to the some of these issues around you say fragile vaccine confidence, but just to this issue of rushing a vaccine. I mean, we have historical cases to look at here. I mean, you wrote about the Qatar incident. Can you say a little bit about that and what we should know about that as a way to think about what could go wrong here?
Yeah, I think The hardest part of making a vaccine, I've only been part of one vaccine, but I was fortunately part of a team at Children's Hospital of Philadelphia that created the strains that became the rotavirus vaccine. That was a 26-year effort. Rotavirus is a virus that causes fever and vomiting and diarrhea. In this country, it would cause about 75,000 children to be hospitalized every year with dehydration and about 60 to die. In the world, it kills about 500,000 children every year before there was a vaccine. So which is basically the same number of people who have died totally of COVID-19. This virus did that every year in the world. So hence the interest in making a vaccine. But and that was roughly a 26-year effort. But what I learned from all that, the hardest part of making a vaccine is making the vaccine, mass producing the vaccine. I mean, that was what happened with the polio vaccine. I mean, that was warp speed 1. Which is to say, while they were doing that trial to see whether or not the vaccine worked, to see whether or not the vaccine was safe, 5 companies mass produced it at risk. Now the risk was taken away from them financially because the National Foundation for Infantile Paralysis or March of Dimes paid for that. So the companies really weren't paying for anything. If the vaccine didn't work, that vaccine would have all been thrown away. But it did work. Then came the problem. I mean, what we found out when that vaccine was then released in the United States in April of 1955, that one of the companies, Cutter Laboratories of Berkeley, California, made it badly. They didn't inactivate the virus well enough. And so as a consequence, 120,000 children were inoculated with live, fully virulent polio virus. Of that 120,000, 40,000 developed short-lived polio, 164 children were permanently paralyzed, and 10 were killed. I think it was the worst biological disaster in this country's history and gave birth to vaccine regulation. But all the companies had trouble inactivating the virus. It should have been called more accurately the scale-up incident, because scaling up is hard to do. I mean, it's not hard to make a few hundred doses in your laboratory and then test it in phase 1 or even phase 2 trials. It's really hard to make millions of doses because a lot can go wrong. I mean, you have to have the right buffering agent. You have to have the right stabilizing agent. You have to do real-time stability studies. You have to have the right vial. You have to make sure that when it goes out from your manufacturing plant, that it's stable. That when it goes to the tarmac, from the tarmac to the person's arm, that it can stand high temperatures and stand low temperatures. That's hard to do. I mean, we're talking endlessly about Moderna's messenger RNA vaccine. The messenger RNA just contains that gene that codes for the spike protein of coronavirus. That's the protein that attaches to cells. If you can prevent the virus from attaching to cells, you can prevent the virus from infecting cells. So all the strategies to make a vaccine are directed at that protein. So hence the mRNA. Well, mRNA is a pretty labile molecule. I mean, the good news is it breaks down quickly in your body. The bad news is it breaks down quickly outside of your body. So you have to find a way to stabilize it. And this has never been done before. This has never been scaled up before. So you have this complex lipid delivering system that you have to use that's never been tested before. I mean, you take a step back for a moment about where we are with this virus. Here's a virus that's been around for 7 months. It's a bat coronavirus that just made its debut in the human population. We've already found a few things that are surprising. One, it doesn't act like a typical respiratory virus from the winter. I mean, flu's gone, yet this virus still rages. It causes this unusual disease in children, the so-called Kawasaki's-like disease and toxic shock syndrome-like disease. Human coronaviruses don't do that. I mean, that's a surprise. It also affects the vessels, causing vasculitis, inflammation of the blood vessel, which causes this sort of hyper, clotting syndrome. Human coronaviruses don't do that either. So that's 3 surprises. Here's a 4th surprise, by the way, which was discussed recently on a podcast called This Week in Virology. John Udell, who's the head of virus research at NIH, brought this up. It's interesting. I mean, there are people who get infected with this virus who have symptoms, significant symptoms, who never develop neutralizing antibodies, meaning antibodies that neutralize the virus's ability to infect a cell. Never develop it. Now, the protein that induces neutralizing antibody is abundant on the surface of that virus, and the virus is reproducing itself thousands of times. You see that protein over and over again, but you don't make an immune response to it? Why? I mean, he brings up the possibility that this virus may have an immune suppressive effect, like the AIDS virus. I mean, that's surprising. And the other thing that's surprising, sorry, this is what happens when you get a virologist on the show. The other thing that's surprising.
No, keep going. We're into 5 now. Go ahead. Yeah.
Let's rant. The other thing that's surprising is that people will, the test that people do to see whether or not you're infected is something called PCR, polymerase chain reaction. Well, that doesn't detect infectious virus. It detects virus genome. It detects the RNA viral genome, which is what is the genome of this virus. You shed infectious virus for 5 days, 7 days. You can be positive by PCR for as long as 12 weeks, which means what that says is because this messenger RNA that the virus makes is very labile, that what the virus is doing is continues to make its genome, but it doesn't make whole virus particles. Why would it ever do that? So now you have 5 big surprises from this virus. To meet this, what we're doing, Warp Speed, has 5 vaccines in it, 5 vaccines. None of which are commercial product that has any analogy to a commercial product in the United States. I mean, if you took the virus, for example, and made an inactivated viral vaccine, you take the virus, grow it up, kill it with a chemical. There are examples of that. Inactivated polio vaccine, hepatitis A vaccine, rabies vaccine are all inactivated viral vaccines. The strategies that are being used to this, so-called genetic strategies, mRNA, DNA, the so-called replication defective simian or human adenoviruses, this vesicular stomatitis virus, which is what we use to make the Ebola vaccine, but that's not a licensed product in the U.S. None of those are licensed products in the U.S. None of those have an analogy to a licensed product. So you have this bad coronavirus that has all these surprises that you're going to meet with strategies, vaccine strategies that have never been used before. I mean, don't we think it's remotely possible that we're going to learn some things over the next 2 years that we don't know now, that we wish we knew now? So that's why it really bothers me when you hear these companies like Johnson & Johnson, who is working with with the simian, the replication defective adenovirus 29, or AstraZeneca, which is working with the UK group, the Jenner Institute group at the University of Oxford, on a replication defective simian adenovirus. I mean, these have never been tested before. People, they're so confident, and those press releases are so confident. How about a little humility? Why don't we assume we're going to learn some stuff? I mean, sorry, one last part of this, man. I was fortunate enough to work on a rotavirus vaccine. Rotaviruses were known to be a cause of disease in animals since the 40s. They were known to be a cause of disease in humans since the 70s. Okay, so decades of experience with this virus, decades of published studies with this virus. When that vaccine, the first rotavirus vaccine came out in 1998, it was found to be a rare cause of intestinal blockage, so-called intussusception, and was taken off the market in 10 months. That was a surprise. And that was after decades of experience with that virus. Here you have a virus where you have 7 months of experience. You have these novel vaccine strategies. I really wish people would stop being so sure of themselves, because nature gives up its secrets slowly and grudgingly and invariably with a human cost. And I just wish people would put on the brakes a little bit. I'm done. I'm done with my rant. That's it.
It's not a rant. It's everything we need to know about the complexity of the situation from the scientific perspective. And I want to ask you, I guess, connected with that, then what does it say to you about Americans that they seem to be so confident that we will have a vaccine quickly? I mean, I wonder about the relationship between these two things, because at some point, Trump and others, many others, across political spectrum, said, maybe this got away from us, but we'll get the vaccine and then let's just ride it out till then. There's this sort of notion that technological fix to this medical disaster is out there waiting for us. And you're telling us here, slow down, guys. This is enormously complicated and there's a lot to learn. Why do we have such faith in this? Not that we have faith in a vaccine itself, but that it can come so quickly. Where does that come from, do you think?
I think we believe in the magic pill. I mean, just walk into a GNC center and you'll see what I mean. But it's, that there's this magic fix to things that, I mean, I think certainly Trump supports that hydroxychloroquine, Clorox chewables, whatever. I just, that there's this thing that makes it all go away. I do think people should, first of all, let's take the optimistic point of view that we will have data by the beginning of next year that shows that one or more of these vaccines is safe, at least in 20,000 people, and is effective, at least for a short period of time. We're not going to know how long these vaccines are effective until they're out there for a while, but at least effective for a short period of time. Realize this, it's in all likelihood, given that this is a respiratory virus, in all likelihood, it will act like other respiratory viruses, which is to say that protection will be afforded by the vaccine will be incomplete and short-lived. By incomplete, what I mean is you'll be protected against moderate disease. You'll be protected against severe disease, which is good because that'll keep you out of the hospital and it'll keep you out of the morgue. But you're probably not going to be protected against asymptomatic infection once exposed, and probably not protected against mild symptoms associated with exposure, which may mean you're still shedding, which is going to be an issue. And if you have, there's a formula for this actually, but Dr. Fauci was on television today on CNN, and he said he hoped that the vaccine would be 70 or 75% effective. If it's 75% effective, which would be great, I think everybody would be really excited about that if it was 75% effective. If it's 75% effective, then you're going to need to vaccinate at least 2/3 of the US population to stop spread, meaning to get that so-called R0, the reproducibility index, to less than 1. 2/3 of the population are going to have to be inoculated with a 2-dose vaccine. That's a lot to ask, especially in a population that isn't even willing to wear a mask. So we'll see how this plays out. It's not going to all go away. Even if there's a vaccine that's effective at 75% level, it'll probably take us, assuming the virus continues to do what it's been doing, probably take us a couple of years to get to the point that we can say the transmission has been stopped.
What do you expect is the overlap, the Venn diagram between those who are unwilling to wear a mask and those who would not be willing to take a first batch, first round, first pass of a COVID-19 vaccine?
See, I don't know. I mean, I think there is an anti-vaccine sentiment in this country. It's true. I mean, we eliminated measles from this country by the year 2000. It's back principally because a critical number of parents have chosen not to vaccinate their children. And people bring that up a lot in these discussions on TV. But this isn't measles. This is a virus that is killing 1,000 people a day in this country. This is a virus that's making it hard for us to walk outside, without wearing a mask.
Right.
This is different. I think if we had a vaccine that at least was safe in 20,000 people, a vaccine that at least was effective at, say, the 70 or 75% level, I think people would get this vaccine. I have to believe that's true, because then they can feel more protected against moderate to severe disease, which is reasonable. But I think we have to explain ourselves. And we have to manage expectations. I think once we know what the data are with these vaccines, and I think it'll be more than one vaccine that rolls out in the US, we need to really educate the public about what we know, what we don't know, what we're looking for, so you can manage expectations.
So I know you're not too hopeful for the October or November rollout. What would you think would be a reasonable time frame that we could begin to see vaccine, even at that 75% effectiveness rate?
Meaning, when would we be getting it, you mean? Yeah. I think early next year.
Yeah,
possible that everything works well. If we do trials in areas, hotspots where there's enough disease in the placebo group that you can really make reasonable claims about efficacy, then I think we could have a vaccine by early next year, assuming everything works well.
And what's the procedure for determining who should have access to it first? I mean, I don't really understand how that works. Does the federal government set guidelines for that? Does that done state by state? Who gets to say who gets it and who doesn't?
Well, the CDC, I think. I mean, the CDC on Wednesday had something called an advisory committee for immunization practices meeting just a few days ago. And the statement that was made was that the first group to receive these vaccines will be who you expect. Say frontline responders, meaning people who work in the healthcare industry, people who work in pharmacies, groceries, people who work in meat packing plants, people who work in nursing homes, people who work in mass transit. Those are the people who probably would get it first, and then we'll work down. I can tell you this, though, at least the way that we have directed this at the NIH level is that I don't think children actually are initially going to be tested to see whether the vaccine works in them, because they're such a low priority group. They're much more less likely to get this disease. When they get it less severely and for a shorter duration. So I don't think they're going to be the first group tested. You want to make sure that you tested it in a representative population of the United States before it gets out there. The representative number of African Americans, Hispanic Americans, Asian Americans, older Americans, women, including women who are pregnant. You have to check all those boxes. Children are not going to be an early box.
I wanted to come to a question, just remind everybody you're listening to COVID Calls, and you can get your questions in on YouTube Live in the chat. This is a question from Caroline Slamma. She's asking, can Dr. Offit explain the current thinking on COVID-19 and antibody-dependent enhancement? So you'll have to explain to me a little bit about what that means. And does that affect vaccine testing?
So what antibody-dependent enhancement means, and the best example of this would be dengue virus. There are 4 different types of dengue virus. When you're infected with one type, and then you're infected with a second type, you actually have a much worse disease than you did the first time. And it's because what happens is the antibodies that you generated really sort of bind to the virus, but don't neutralize it. And therefore, when they bind to it, they actually bring it into the cells through something called the FC receptor of the sort of the non-business end of the antibody molecule. That's an unusual occurrence. It is possible that could happen here if you get a lot of binding antibodies but don't get neutralizing antibodies. People are looking at that. The thing that worries me more actually is not antibody-dependent enhancement. It's something else. In the 1960s, we had a vaccine against something called respiratory syncytial virus, which is a respiratory virus. It sounds like it is a respiratory virus, and still causes thousands of children, really young children, to die every year in the United States. So the way that vaccine was made was they took the virus and inactivated it with a chemical, formaldehyde. When children got that vaccine, they were exposed to the natural virus, the wild-type virus, the virus that's circulating. They did worse if they got the vaccine than if they hadn't gotten the vaccine. They were more likely to develop pneumonia, more likely to be hospitalized, and more likely to die if they got the vaccine than they hadn't gotten the vaccine. I'm going to explain why in a second and why it matters here. Also in the 1960s, there was a measles vaccine that was made the same way. Take the virus, inactivate it with formaldehyde, and the same thing happened. Children who got that vaccine were worse off than children who didn't get the vaccine. They had something called atypical measles and measles pneumonia. Both of those viruses have on their surface, the part of the virus that attaches to cells actually is a fusion protein, meaning the virus is fused to the cell, which is unusual. Not all viruses do that. Some just attach and enter by a process called endocytosis. This is a fusion issue. Now, why does that matter here? The spike protein on coronavirus is a fusion protein. So, if you make an inactivated vaccine, as the Chinese are doing, actually, they have an activated vaccine that's already in phase 3 trials in Brazil. They didn't use formaldehyde. Good idea. They used something called beta-propiolactone, which is what we use to inactivate the rabies vaccine. So I think they're going to be fine with that vaccine. But that's what worries me. If that's it can happen. I don't, but there are systems in place to make sure it doesn't happen. The so-called vaccine safety data link. The minute these vaccines roll out in the United States, because not everybody's going to get them all at once, you're going to know who got them and who didn't get them through this linked computerized medical record system with a variety of large HMO, health maintenance organizations. So whether there's a problem, I don't think there's going to be a problem, but people are looking for it. Any product that has a positive effect will have a negative effect by definition. That's true in every aspect of medicine. You just want to make sure that the benefits clearly and dramatically outweigh the risks. And obviously, the benefits of this vaccine are great when 1,000 people are dying every day. So, but I think it would be silly to think there will be no risks to this vaccine. There will be, and we'll learn about them as we go. And I suspect that they're going to be far less than the benefits of the products.
Can you just sketch out in general sense for us, the legal liability for pharmaceutical companies putting a new vaccine on the market for the first time with something like this coronavirus?
I'm not sure. I mean, I assume if the vaccine is recommended by the Centers for Disease Control and Prevention, which I am sure it will be, then I imagine it becomes covered by the Vaccine Injury Compensation Program. So that you can't sue a pharmaceutical company directly. You have to first go through this so-called vaccine court, which at least puts a firewall to some extent between the company and the civil litigant. And I imagine that's the way it'll play out. It may play out the way that the swine flu vaccine played out in 1976, which is the government just covers all liability. We'll see.
Is something like that done on the front end to inspire companies into the marketplace, that the government will send signals that there would be this sort of backstop there in case something went wrong? Or does it happen the other end, that the litigation and political pressure builds and then you get a sort of compensation fund in your experience?
No, well, there's a compensation fund in place, the so-called Vaccine Injury Compensation Program. So I imagine things would go through there. It would make the most sense. It's the fairest way to do it.
I see. So obviously, I'm a professor at a university. You're a professor at a university. We're having these discussions all summer as to what it's going to look like to try to bring college students back to a campus. States that have even taken a conservative approach, like New Jersey and Pennsylvania, New York, are talking about bringing students back in the classroom in the fall. What's your sense of the wisdom of that right now? And can we do that without a vaccine?
Well, we can certainly do it without a vaccine. I guess the question is, can we do it reasonably?
Well, should we do it? Should we do it without a vaccine? Yeah. Yeah.
I really do think children should go back to school, and they are a very low risk group. And you have to do the best you can to make sure people wear masks when they're inside and close together. The people I worry about more there are the teachers who are older and may have comorbidities. Right. But I mean, because there is another side to that. I mean, when they stay home, first of all, it's very hard. Learning at home doesn't work very well, frankly. And when they stay home, they're more likely to be around grandma and grandpa. So, and the parents aren't able to work because they have to take care of their children at home. So there's so many ripple effects of not sending kids to school. Personally, I think they should go. But again, the best person to ask that question to is Dave Rubin, who's head of the policy lab at Children's Hospital of Philadelphia. He's a wizard on this kind of stuff. I'm just a virologist with an opinion.
Are you teaching at this time?
Sure. Well, I mean, yeah. Well, I taught teaching online. Yeah, with some courses. Yeah. Another course starting in August that on the cell molecular biology, vaccines and immune therapeutics course we're going to be teaching. So yeah, I still teach.
And the first time you've taught online these subjects, or have you done that before?
No, it's the first time I've done it. It's weird.
What have you learned?
I learned that, if you make jokes, you can't tell whether or not you're funny because you can't see whether people are laughing. That's the first thing. You just in your room making jokes to yourself. That was one thing. Also, you obviously feed off the crowd. You can tell whether you're connecting with your audience or not, but when you're online, you really can't tell. And so it's not nearly as fun.
So the kind of more informal tools you use as a teacher or a speaker, you feel a little cut off from those, I suppose.
Right.
Yeah, I felt the same way myself. I wanted to, since you're so prolific and you just have a book out, and I wanted to ask you if you wanted to talk a little bit about the most recent book.
Sure. Yes, I wrote a book called Overkill: When Modern Medicine Goes Too Far. It's published by HarperCollins in April, but it's about sort of 15 situations in modern medicine for which there's abundant scientific evidence that we shouldn't be doing something, but we do it anyway. Like treating fever, finishing the antibiotic course, prostate screening programs, which don't save lives, thyroid cancer screening programs, which don't save lives. The vitamin D, I think, is largely a hoax, but in terms of the degree to which it's used. So I go through those sort of situations. The business about putting in cardiac stents, which has gotten me the most negative feedback. But I just go through the data. I mean, I try and explain the data that's out there in the simplest way possible, and compel the listener to at least, or the reader to at least, ask better questions when they go to their doctor's office. Because there are certainly things that I learned when I was a pediatric resident that were wrong, and that's still true today. Why we don't, when you start to feel better when you're getting your antibiotic, you're probably done. There's now abundant evidence that shows you're done. I mean, why do we pick an arbitrary length of time at the beginning of illness? You have to treat your bladder infection for 7 days, when after 3 days your urine's clear, your fever's gone, your pain's gone. I mean, you're good. And why 7 days? It's always like some multiple of it's not, bacteria don't reproduce themselves on the basis of the lunar month. So I don't know why we assign a time at the beginning of illness. And the premise was always wrong. Because the premise is always like, well, if you don't finish your course, then you're going to create resistant strains. The opposite is true, not surprisingly. The longer you treat, the more likely you are to create resistance, as study after study has shown. But we just can't seem to shake this. In any case, that's one of many examples.
I'm going to have to spend some time thinking about what you just said, because it completely rewires my brain and what I've been told my whole life. Take the full course of antibiotics, because that last germ that you kill on the 10th day was the true warrior, and you're telling me that's not true.
Not true.
No. Okay. But you finished this book before the epidemic started, right? So that must be kind of an interesting experience. I mean, as a disaster researcher and person who writes about disasters, and I have a lot of colleagues in the same place, we're writing about something and then all of a sudden September 11 happens, or we're writing about something else and then Katrina happens and the whole world seems to tilt a little bit. Have you started a COVID-19 project?
No, I'm still recovering from this. I mean, it's interesting, right? The book comes out in April. There's a good thing, right? Because now you have a book that's come out. I mean, HarperCollins did what they could to promote it. I love the book. But, it's a little hard to publish a book when not a single bookstore in the universe is open and no one on any media platform wants to talk about anything other than this virus. So it's been a little frustrating. I'm sure much more frustrating for the PR people at HarperCollins, but I imagine that this will settle down at some point.
Well, I hope people will pick it up. Overkill when modern medicine goes too far. And I mean, to make it even harder for you, at least for some period of time, if you ordered it via a internet service provider like Amazon or somebody like that, we had to be concerned that we might get sick even touching the box when it came to our house. I'm not hearing recommendations about scrubbing our mail much anymore, but I'm sure it will. I'm sure that people will pick it up and read it, but the hardship that you're describing is one that, people who've been working on disaster projects coming into this year, myself included, all of a sudden it's like, I've got to add a few new chapters here because this is really shaking a lot of what we thought about how disasters were managed in the United States. And I guess with that in mind, I mean, how is this changing the way you think about pandemics and politics in America? Is this, hopefully this is some sort of exceptional moment, or do you think something fundamental has shifted in the way that our surveillance and our management of a national scale pandemic works?
Oh, I think at an international scale, you're absolutely right. I mean, I think this is not going to be the last novel virus to start to sweep across the country. I mean, SARS was a warning shot, MERS was another warning shot, and then this was the big one because it can be transmitted without symptoms, which I think means everybody is potentially a shedder who could hurt you. And no, I'd like to think there are now systems that will be put in place, especially international surveillance systems. You had China, you had to really rely on a whistleblower in China to tell you that a virus was sweeping through Wuhan and killing people. It should never have happened. I mean, we should have known about that immediately and didn't. And I think that should be true for whatever part of the world the next virus crops up on. But I'd like to think that is a permanent lesson learned.
And as far as medical education goes, do you see any changes in this moment as a result of COVID-19?
I don't know. I mean, certainly I think it's going to change businesses. I mean, do you really need to travel as much now that everybody is, it's sort of having these Zoom calls? I'm sure it'll change business. I'm sure it'll change travel, national, international travel. I'm not sure if it'll change education. I mean, I hope not. I mean, I hope we get to go back and teach in person again because I really don't like this sort of Zoom teaching. It's not as much fun for me.
Well, something you said a minute ago was, and you've written about the anti-vaccination, I don't know if we call that a movement or politics or whatever it is, a worldview. But I thought it was interesting that you said that the urgency of this may tamp down some of that. I mean, you really understand that movement inside out. What do you think in this particular moment? Are we in a space where COVID-19 fear is such that it can overwhelm maybe the sort of forces of the anti-vaccination movement, or is that now just too politically strong? It's too structured in our society, and it's always going to be there as a form of politics?
Well, so I think there's two groups. I think that the group which is the most common are people who are just skeptical about vaccines, which is reasonable. I think you should be skeptical of anything you put in your body. I think everybody that sits around the table at the FDA's Vaccine Advisory Committee is skeptical about vaccines. We want to see the data. Sure. And that's most people. They don't see these diseases anymore. Do they really need to get these vaccines? I mean, but they're convincible. They're convincible with logic and reason and data. I think that the true anti-vaccine activist, to me, is a conspiracy theorist. They just think there's a big conspiracy that's run by the pharmaceutical industry that has the government in their pocket and the medical establishment in their pocket, and they're not going to believe anything you say. They're immune to logic and reason and data. So forget it. They're a very small percentage of people. So I think the other thing that people don't consider is when people are scared about that, people often equate the safety of a vaccine with the danger of the virus. So people are sort of scared of an Ebola vaccine or an anthrax vaccine because those are such frightening diseases, but as if the vaccine then would be more dangerous, which isn't true. I mean, that's not logical. That's not true. Going to be true here either. So I think that's also sort of part of it.
I see. Well, we're almost up on time. I got one question in, and it's actually a good one to end with. It's very broad, but I like it. And it's, what's one change you would like to see in the United States as a result of this pandemic we're living through?
Other than the obvious one, which is
one. You get one.
Fire Bill Barr. No, just kidding. That's not what you want to hear. What one change in the United States as a result of this pandemic? Well, that we have a pandemic preparedness program that's in place so we can have PPEs quickly, so that we can, make sure that we can do the kinds of work on antivirals or whatever quickly. To put that in place, I mean, this hopefully has scared us straight.
I want to remind people you've been listening to COVID Calls. Tomorrow at 5 o'clock, we're going to be having the 5th of our Academy of Natural Sciences conversation. Is going to be talking to Julian Siggers of the Penn Museum and Scott Cooper of the Academy of Natural Sciences. And you can catch COVID Calls every day at 5 o'clock Eastern Time. Paul Offit, it was a really powerful hour. Thanks a lot for making time for this discussion.
Thank you, Scott. My pleasure. Enjoy. Stay safe.
Stay healthy, everyone. See you tomorrow. Thanks.
Bye-bye.